2025 has been a year of significant shifts in healthcare. At a State of Reform Health Policy Conference this fall, 4 of Minnesota's healthcare leaders came together to discuss some of the problems they're facing, possible solutions, and what the future may hold. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm Abby Mochtig. In this episode, we'll listen in on a conversation from the State of Reform Conference, held in Bloomington this fall. The panel included Children's Minnesota CEO Dr. Emily Chapman, North Memorial Health CEO Trevor Sawallish, Winona Health CEO Rachelle Schultz, and Fairview Health Services CEO James Hereford. Rahul Koranne kicked off the conversation.
I am Rahul Koranne. I am a dad this morning with kids logistics, but I made it here on time. So thank you to everybody that showed up here bright and early on this beautiful day. I'm also an internal medicine physician and a geriatrics physician. And before I turn it to the 4 CEOs from across the state, I just want to reflect upon the caregivers on the front line. Up here on the podium, you have about 150 years of healthcare experience, leadership, and frontlines work. We have the privilege up here on the podium to support caregivers, volunteers who do the hard work. So Paul talked about so many tremors that are happening in the society around us, starting with the globe, down to the country, down to our own state here and our own region here in the upper Midwest. So I want to begin just by reflecting upon what I did here in Minnesota for 25 years as a frontline care provider, as a primary care physician, as a geriatrician, and sometimes a pediatrician in the smallest critical access hospital in the state of Minnesota in West Central Minnesota, Starbuck, for 5 years, and then a large healthcare system in the Twin Cities, Health East Care System, which is now part of Fairview. And as we talk about what healthcare and nonprofit healthcare is going through, I want to begin with that reflection that what we support here are those hundreds of thousands of caregivers that right now, this particular second, are serving our neighbors, our families, our friends across the state and across the region. As Paul said, there's a lot going on, and a lot is needed from policymakers that are in the room, from state agency leaders, from national agency leaders who are based here in Minnesota, and from other stakeholders like employers and nonprofit organizations, social service agencies, and of course, mostly our elected officials who are also in the room, because healthcare and nonprofit healthcare delivery needs you. Before I turn it over to the CEOs, one last comment. We could take the next 8 hours talking about the violence that is happening in our communities, that our caregivers see, not just when they respond as EMS providers, but also as caregivers in our emergency departments or in our trauma operating rooms. We could talk about evidence-based and what is evidence-based around even generic, simple medications or vaccines that protect us. Or we could talk about what is happening in our communities flowing into our hospitals and health systems. But that would be very zooming in to issues, and we could talk about that for 8 hours with all four of these CEOs. But I think what would be more important is to zoom back out. Zoom out a little bit and talk about the nonprofit delivery in a little bit more of a systematic, holistic way. Look at it from the balcony instead of focusing in on the issue of the moment or issue of the week, heartbreaking as they might be. So we have CEOs from across the state, who have sites up north, who have hospitals down south, who have hospitals in the Twin Cities. So let's take you a little bit on a tour of the nonprofit hospital and health system care delivery beginning with a system that has hospitals in the Twin Cities, but also hospitals up in the northern part of our state. So I will turn it over to James Hereford from Fairview.
Thanks, Rahul, and thanks for having me here. Appreciate HMA putting on this conference. As Rahul indicated, my name is James Hereford. I contributed to a good share of those 150 years of experience, I suppose. So Fairview is a fairly large healthcare system. Our total revenue is $8.5 billion, something like that this year. We have rural presence, suburban, metro presence. So what Rahul asked me to do is kind of talk economics 101 of healthcare. And I will bore you to death over multiple hours. I'll try to abbreviate it. So I was trying to think about what the opposite of reform is, and it seems like it's disillusion. Because I think we're dissolving as a healthcare system. I think of this healthcare financing as a big Jenga tower, right? And you guys have all probably played Jenga with your kids, and the whole object is to take pieces out without the tower falling down. We are actively taking the pieces out of our Jenga tower of healthcare financing. So the first step in that will be removing the ACA subsidies. So these are subsidies to help the working poor be able to purchase insurance. Those are going away. Now, the question is, what happens to those folks in that care? Well, clearly the coverage goes away because they need those subsidies to be able to afford the insurance. So without those subsidies, they're likely not going to be insured. But their care needs don't go away. But their patterns of care will change because they won't have a relationship with a primary care physician or any kind of system. They'll present in the ED. But they won't present in the ED at their first sign of symptoms. They'll wait until those symptoms become increasingly acute, and then they'll come to the ED, and there'll be a higher likelihood of inpatient admission and significant more costs. But what will happen is hospitals will, in large part, absorb those costs because we have to. Well, I've heard this described, OB3, as we're basically replacing the ACA with EMTALA. As you're probably familiar, EMTALA is the legislation that requires us, without checking for ability to pay, to care for people in the ED. And that's right. That's the way it should be. Our first priority should be caring for those patients who present in our emergency departments. But at the same time, and I'll get to the economics of this, it's difficult to say, well, that's what hospitals should do, is be the safety net, because we choose not to insure people or help them get insurance. All right, so I'm going to back this up a little bit. The Economist had a great article, I think it's 3 years now, about this time period, that talked about our $4.5 trillion industry. That is the healthcare industry in the U.S. It is a very large ecosystem. Now, hospitals and healthcare systems get a lot of scrutiny. I think there's, for some, an image that, as a CEO of a healthcare system, I'm flying my private jet to the Bahamas, and I go to work and I sit on these big gold bags, just hoarding my wealth. Not the case, right? Not-for-profit healthcare doesn't work that way. But hospitals are about half of that $4.5 trillion spent. And so I understand that when people say, well, those darn hospitals are taking so much money, it's so expensive, right? I get my bill and I don't understand why I'll use the Tylenol just for fun, the Tylenol costs $72. There's nothing rational about healthcare financing, so let's start there. But the problem for hospitals in that focus of their half that spend is it does two things. It removes the focus on the other half the spend, which are all the middlemen in healthcare, right? That's payers, PBMs, distribution companies, health tech, iTech, all the equipment manufacturers, et cetera. That's the other 2.25. Now, on the half that is the hospitals, look at the average margins. Right now, 2/3 of the hospitals in this country are losing money. And remember, we run these very large buildings, very complex settings with very expensive equipment. So you need replacement capital. That's the thing about a not-for-profit. We don't have to worry about distributions and quarterly analyst calls and, all the things that you have to worry about as a publicly traded company. Our money goes back into our environment, into our hospitals, into our equipment, into our people to maintain that. But that is also where the value is, right? So if you have a heart attack, a stroke, you have a traumatic accident, et cetera, you want that hospital open, 7 by 24 by 365, there to respond. But the problem is, our assumption is, as a not-for-profit, you're going to be like the tap water, right? You open up the tap, the water comes out. And increasingly, this economic environment, right? First with the ACA cuts, in 2 years, the pretty significant Medicaid membership cuts, which will take away coverage, but won't take away the need for care, puts increasing stress on that part of the ecosystem. Meanwhile, the other part of the ecosystem, if you look at their profit margins, and especially pharma, are doing quite well, thank you. Now, pharma hates the 340B program, right? So a 340B program is the requirement that for DISH hospitals, so those hospitals that serve a disproportionately poor population, they have a discount program from pharma to purchase those drugs, outpatient drugs, to be able to then use to support their care operations, to support that DISH hospital. If you took away the 340B program, right, which, remember, pharma's making 15 to 20% annually in their profit margins, so you'd take it away so they could have higher margins, you would put 2/3 of the hospitals in the country out of business, including most, if not all, of the hospitals here. I heard the Pennsylvania CFO, the UPenn healthcare system, describe Penn as, we're largely a specialty pharmacy company that happens to run some hospitals. That's how dependent healthcare is, and healthcare delivery is on that single program. But just maintaining that program is going to be wildly insufficient. And I'll kind of stop it with one more point. So I was in California before I came here. I was at Stanford University. So it's almost the antithesis of Fairview, right? High-ranking, academic, but oh, by the way, our payer mix was about 60% commercial, and our reimbursement rates were anywhere from 500% to 600% of Medicare. I was the smartest guy in the world. It was easy to make, sufficient funds to reinvest at Stanford. Now, if you come to the Twin Cities, and much of Minnesota is the same way, and you look at the commercial reimbursement levels, well, commercial reimbursement levels are under 200% of Medicare. And you all are probably very familiar with the weird Jenga game that we play, which is Medicaid pays us about 68 cents on the cost dollar. So every Medicaid patient we all see, we're losing money on. Doesn't keep us from seeing them, but what we have to do is then balance that against the commercial reimbursement rates. But what I describe to my board and my team to the point that they're sick is, it's the 2%, 4% problem. So my blended revenues at best go up about 2% per year, contractual revenues, between commercial payers and then what the government gives us. My costs go anywhere from 4 to 6% every year. So I mentioned we're an $8 billion-ish organization. That 2% delta means we have to take out $160 million every year to stay even. We're not gaining, but it keeps me in a position where I can employ 34,000 people and have 4,000 physicians working in our system, seeing 1.2 million unique Minnesotans. But every year, we have this 2%, 4% problem. And what we do is oh, that must be the sign, I'm done. We have to cross-subsidize between the commercial payers. And in the Twin Cities, the commercial reimbursement rates are not that high. They're under 200%. So you start with fairly low commercial reimbursement rates, and then demographics work against us. So the mix of Medicare, Medicaid has continued to go up, right? Because people get older, they age into Medicare. We see more Medicare. But as a payer, it's worse. And so that's where this Jenga tower is starting to fall. So we'll see more uninsured, lower reimbursement rates. Commercial, we continue this, it's almost like a hidden tax on business, right? Because they have to pay for the delta to make up that 2%, 4% problem, and as we can't cover our expenses with Medicare and Medicaid, they have to make that up. The problem, though, is that those commercial entities, our employers, we're fortunate in Minnesota to have so many great employers, look at their P&L and say, well, what's the fastest growing line on my expenses? It's health coverage, it's benefits. Now, what they've done over the last 20 years is essentially push more and more of the cost to the individual. So I remember the rhetoric in the early aughts was, yeah, we're going to introduce high deductible plans because people are going to have skin in the game, they've got to have their head in the game, and this will help do that, right? Deductible then was $200. Average deductible in the US is $5,000. Now, who is accountable for collecting that $5,000? That's patient responsibility. So it's clearly the patients are responsible. But what the plans have done, I don't know intentionally or just luckily, is basically shift a bunch of the economic accountability for collecting what was premium to direct cost to consumers. And it's on us to collect that. And obviously we don't collect it 100%, nobody does. And so again, you have this directional problem, and especially as those deductibles continue to increase, right? We know in the US, the vast majority of people can't handle a $500 unexpected bill. I got to tell you, the bills that we send out for the work that we do are a lot more than $500. And so we've also, not only we've had this hidden tax on corporations and large entities, we also have this hidden tax on individuals in the form of cost shares. Now, what we've done over the last 20 years is basically try to sap every possible source of more money coming into healthcare. And I will be the first person to say healthcare is too expensive, affordability is our key issue. To the degree that we can't manage affordability effectively, we're not going to be able to manage this transition that we're going to have to make in healthcare. We've got to make it more affordable, more accessible. That means we're going to have to be able to leverage technology, leverage, reform in terms of clinical models, et cetera. But we're not going to have the resources or even necessarily have our doors open in order to be able to do that if those revenues continue to have downward pressure. Or what employers end up doing, and they have a pathway to do this, they're in the defined benefits game right now for the most part, right? That you buy a set of benefits. It's the one area of benefits for corporations that remain a defined benefit. Most are defined contributions. I'm sure most of you have your 401k, et cetera, right? I give you the money, you invest it, it's on you, you have all the risk. Commercial entities have the opportunity through a provision called ICRA, which allows them to be able to make defined contributions to individuals. And then individuals have to go out to the individual market. You may say, well, that's no big deal. I mean, they're still insured, right? Yes, but the premium rates that we get for the individual market are quite a bit lower, slightly above Medicare, but quite a bit lower than normal commercial rates. So again, you get this downward revenue pressure. Another piece in the Jenga tower comes out. And so that's the state of things, right? I think, and I especially, a couple of my colleagues have interesting circumstance, being a rural CEO or an urban CEO where you have a disproportionate share of patients who have, Medicare, Medicaid. This is the ecosystem is dependent on each other. So we may say, well, it's tough to be rural for a lot of reasons, but it'll be fine. No, it won't, because you can't not have those healthcare systems and those hospitals in those rural towns. There's no way that, Fairview or anybody else can project all that care into the ecosystem. And if the finances don't work, it's not like you can just roll up all the rurals into a large system. That doesn't work. So if we don't arrest this slide, what's going to happen is these small rural hospitals are going to start to go out of business. And we're already starting to see some signs of that. And when they do, this whole ecosystem will collapse. So on that cheery note, I'm going to stop talking about Econ 101. Thanks, Rahul.
Thank you, James. We are going to go all the way down from the Twin Cities with, some Fairview hospitals up north, down south to Winona. Rachelle.
All right, good morning. Thanks for being up early this morning and coming to this conference and the opportunity for all of us to share a little bit about what's going on in healthcare. So I'll try to put a little color to what happens in rural communities using some of the points that James just went through in terms of the economics. So some of the things to understand about rural specifically, well, let me back up. So I am the CEO of Winona Health, located down in southeast Minnesota, right on the Mississippi River. It's a rural hospital community health system. We have clinics and senior services and some community-based services. And we are what's known as an independent PPS hospital. So there's different categorizations of rural hospitals: critical access, PPS, independent system, and so forth. So that's sort of the background. I've been there, I'm in my 24th year of being in Winona, and it's been a great place to be. So a few things just about, rural communities. You probably know a lot of this, but, our demographics nationally are sort of against the rural, or against sort of healthcare, if you will, just the aging population and so forth. But we feel it a little bit more acutely in rural. We tend to have older populations, a lot more elderly folks in our communities. They tend to be less healthy, and they tend to also be of lower income. So that's kind of the trifecta of issues that we face in our communities. And our hospitals, when we use the term safety net, I remember years ago, safety net was, a county hospital. That's like you had to go, that's where people were taken. That was always there to, serve the underserved and so forth. But I would argue that today every hospital is a safety hospital, and particularly in rural. And it's not just even for healthcare. What I have seen in recent years, as lots of organizations are dealing with workforce issues, funding, all kinds of things. We become a place where, the way I reference it, is everything that's broken and fragmented in our community shows up on the doorstep of our emergency room. So we often find people who, maybe they're on home care, maybe they have other case managers, maybe they're getting services from other agencies. And when those doors, close their hours at 4 o'clock in the afternoon, their go-to plan is, if something happens after that, show up at the ER. They'll take care of you. We have families who, will bring a loved one in because they don't know what else to do. Here, you take care of them. Can you find them a placement? So we are truly a safety net and filling a lot of different needs, if you will, in our community. I also think that in rural particularly, we are kind of our own little ecosystem, and we have a lot of partnerships. And so we work with, the other agencies, the county, other service providers to try to put together the services that everybody needs, or individuals need, to keep them out of the hospital or keep them thriving in the community and so forth. We identify a lot of what those needs are through doing our community health needs assessment. That is a requirement of every hospital. We have to do it every 3 years. Counties have to do it every 5 years. But we've kind of coordinated that, and I think many of us do this in tandem with our counties. And so that's, to get the feedback from our communities. What are the needs? It aligns with our mission, being community-based and oriented that way. And, I would say over the years, not a lot has changed in terms of what the needs are. Obesity is one of those. Mental health is another one of those. But for the first time this last year, we just finished ours a few months ago, access showed up as one of the top issues. We've never seen access being one of the issues in our community health needs assessment. And I think it's really a function of what's coming out, more federally about the cuts in Medicaid. People are really fearful that they're not going to be able to come in for care or get the care that they need, or they can't access insurance, or they're going to fall off of, their plans and not have another way in to get coverage. And so with that, just sort of rolling all of that into the financial situation, of rural hospitals, it's not pretty. And I would sort of describe it as like, we don't have much of a buffer. We have like core services that are really primary care oriented, inpatient, outpatient, ER. Some of us, have, mental health. OB is a program that actually is starting to, we've lost a lot of OB programs in rural communities. So we have what are known as OB deserts in Minnesota. And I know there have been a lot of studies out of the University of Minnesota just around OB care in rural areas. And as financials falter, it's not just OB that we're losing. We're starting to, see losses of other types of services as well. Mental health is, probably right up there, with OB, looking for ways to try to cover services. And the reason our financials are sort of where they are is, I think fundamentally, one is our payer mix. Years ago, similar to what James was describing out in California, our payer mix was more balanced. We had, more commercial, kind of balanced with the government payers. And over these last, probably 5, 7, 8 years or so, we have seen a very steady increase in the percentage of our payer mix moving to government payers, Medicaid, Medicare, Medicare Advantage. The fastest growing plans and enrollments are Medicare Advantage, and they don't even pay as well as Medicare. So we have Medicaid, Medicare Advantage, Medicaid's at the bottom, Medicare Advantage, Medicare, and then commercial in terms of our payer mix. For every 1% change that goes over to the government side, that's $1 million hit, negative hit, to my bottom line. So as we've gone, from maybe the mid 50%, of commercial, of the government payers with commercial, and we've gone up, we're at about 65% now, from 55 to 65%, that's a $10 million hit. Same work, same needs, same staff, same cost, same everything, $10 million less. And we weren't, we never had like a, robust bottom line. We were at a few percent or so. That's put us into the red. So, and there are hospitals in Minnesota that are over 70% in the government payer category. So we do have distressed, hospitals in Minnesota, and I think the concern is, as we've watched around the country, rural is sort of the vanguard of when all these changes are flowing through, what's going to happen? We could lose our hospitals. And to James's point, this is that safety net, that ecosystem around the whole state. I would argue that our rural facilities are really the backbone. We're the first point of entry for folks. And the vast majority of what we do is, prevention, early intervention, chronic disease management, mental health, OB care, all of those things, kind of all together. But if we falter and fail, there's no place for people to go. We learned this coming out of COVID. Because we lost a lot of beds, we lost a lot of staff, all of those kinds of things, and so in rural hospitals, we sort of had to retool and be thinking about how are we going to take care of these folks in our communities, because hospitals that I used to refer to, or our docs were referring to, were on diversion. So big hospitals, small hospitals, we're all in this, together. And I think we really do need some, transformation, in how we're doing delivery care, and particularly how we're financed for that delivery care. So all of these issues, this was sort of an unraveling before COVID. That certainly, threw a bomb in the middle of all of it. And then, we're trying to recover, but we're kind of getting pelted, with some fairly significant other changes coming, and not the least of which was, what was passed in the federal budget. So we're looking at $1 trillion loss in terms of Medicaid financing, which has implications, of course, for the state and all of us as this sort of rolls through. But one of the things that was put back into the budget that actually probably helped that whole thing pass was a $50 million rural health transformation grant program, which all of the 50 states, this is actually a state application that has to go in. And the idea is that, it's half of that money goes equally to all 50 states, and the other half has some different criteria depending on the applications. What's unique about it is that it's like the speed of lightning. The application only came out about a week and a half ago. The state has very little time to put this application in. There's a deadline in mid-November. And the decisions about this grant are going to be made on December 31st by CMS. So even if our organizations move, relatively fast, that is a massively fast timeline to do something that's so significant for $50 billion. And by the way, I'm just going to point out $50 billion doesn't go even a short way to covering the $1 trillion that was taken out in terms of Medicare. But That said, what I will say is, my colleagues, across the Minnesota Hospital Association, certainly all of my rural colleagues, have been very active in pulling information together, ideas, proposals. We've been had the opportunity to meet a couple times, with the state to present these ideas to help support that application going in. I think it is an opportunity. I think that there's some really good work that went into that. And depending on how all of this, rolls out, I think there is an opportunity for us to do some, unique things in the rural space. It is going to take work. The money is great, and if we get that, that'll be nice for us. But it won't solve all of our problems. But it is at least a place for us to start.
Thank you, Rachelle. So now we will come back to the Twin Cities, but go to a system that actually is connecting the outstate and the metro areas through some of your services. So, Trevor.
Good morning, everybody. Thanks for being here. I'm going to give Emily her 10 minutes, by the way. I'm going to work really hard. So Trevor Sawallish, I am the CEO of North Memorial Health. And for those of you who had the misfortune to listening to me, I've talked a lot about the importance of a system like North Memorial and the fact that we are a level 1 trauma center and are serving a population and serving a geography that likely isn't going to get served by anybody else. So I don't want to really emphasize that point a lot. And Rahul asked me specifically to talk about what it means to be a safety net, but as Rachelle just said really well, safety net at this point is any place that catches a patient. Safety net is our level 1 trauma center. Safety net is our Maple Grove Hospital that delivers 5,200 babies a year. Safety net is the ambulance that shows up when you call 911. Each and every component of this healthcare system is at risk, and each and every component of that healthcare system is a safety net because we catch a patient when they need us. So instead of just going on more about kind of the challenges that we have, I wanted to flip it. This is a state of reform, so I thought one important lens could be, let's not talk about the loss, because it's hard for us to imagine the things that we have now going away. But let's imagine that it is all gone away. Let's imagine that North Memorial is not there for 110,000 emergency department visits. We're not there to answer the 911 call for 8,500 square miles of Minnesota geography. We're not there to deliver 5,200 births a year, and by the way, going to be 70,000 total births at the Maple Grove Hospital in the next couple of days. We're not there. Imagine instead that none of that is there, and then somebody wants to recreate it. Some bright-eyed, non-Craigley healthcare executive, I'm too cynical now, I couldn't do it, but some bright-eyed person wants to come and start this system over again. Imagine how that conversation goes. You're going to start all of these services, and let's talk about the economics. How are we going to sustain that? How are we going to keep this nonprofit thing going? Okay, well, my costs are going to go up, right? My costs are going to go up. Labor is going to be 5 to 7%. Supplies are going to be somewhere between 8 and 12%. Pharmaceutical supplies are going to be well over 10% every single year. Then we have to purchase the buildings, the MRIs, all that other stuff. You got all of that cost. Great. We just have to bring in money to cover all that, right? Okay, well, how's the system going to work? Well, the system is going to work by we're going to provide care. Well, who's going to pay for that? Well, for about 75% of the patients that you get on a good day, they're going to be paid for by the government. Great. The government's going to pay its bills? No, not going to pay its bills. They'll pay some of the bills. Okay, great. Some of the bills. Well, how are we going to make up the stuff that they don't cover? Well, we'll charge commercially insured patients. Fantastic. So you're going to get increases to cover all those costs? No, not really. It's going to be a fight every single year, or at least every couple of years. Great. Oh, and besides the point, just before you settle that they're going to pay for that bill, just remember that they're going to be selling higher deductibles, higher coinsurance, higher cost-sharing components of that plan. Oh, great. And then they're going to get that from the patient after you've delivered the care? Nope. You're going to have to collect that. Great. What's the regulatory environment for collecting any of that money? Not that great. Okay, fine. So what are we going to do now? Well, we've got this huge gap. Well, we'll find efficiencies every single year. We'll find that, for us, it's 25 to 50 million every year just to break even. Okay, great. We'll figure that out every single year. Well, let's talk about workforce. Everybody's going to love working in healthcare, right? Yes, everybody's going to love working in healthcare. When they get into healthcare, it's great. Well, hold tight, though. The only problem is there aren't enough of them. Well, why aren't there enough of them? Well, because we don't really do a good job of training the next generation. We aren't thinking ahead. We aren't looking forward to what that's going to mean. Well, what does it mean when you're short? Well, that just means that the cost of labor is going to go up any faster. Well, we'll just charge the government. No, remember that whole part about not being able to charge anybody anything and not getting that reimbursement? Just remember that in everything that you're going to do. Okay, well, how are we going to get people to really enjoy healthcare, to really understand how meaningful these jobs are? Well, we're going to do a lot of press about how hospitals suck. Okay, great. Well, what other press are you going to put out there? Layoffs, mostly. Okay, so you're not going to have enough people. You're not going to be able to cover your bills. You're not going to be able to provide those services in any meaningful way. Right. Why would I start this business? Why would I go into this? How am I going to sustain it? I don't know. That's a really good question. So when we're talking about a state of reform, when we're talking about what can we do differently, I want us to stop thinking about what we're going to lose and start thinking about what it would actually take to recreate it in a meaningful way. Because the reality of the situation is if North goes away, it affects Rachelle and Winona. If Fairview goes away, we aren't training enough people, it affects the entire state. If Children's goes away, I used to work at Children's, that's a really bad scenario, right? Because there's nothing more important than the kids that we take care of. All of this is really important. Any one of those parts goes away, it just puts more pressure on the other part that's remaining, and the whole thing is sliding towards failure. So let's think about what it would take to recreate it in a more rational way. The last thing that I would say is healthcare is really, really special. At the end of the day, it's about people taking care of people. And because we talk about the 340B program and pharmaceutical companies and all of these other components to it, we forget that we're here because this is something that our communities need. This is something that our state needs. This is something that the people of our state need every day. And it is a really, really special place to be. So the only thing I would encourage is we talk about reform, we have to find a way to do it with optimism because we don't have enough people going into this job. And if we don't have enough people going into this job, it's never going to succeed. It's never going to survive because we need people taking care of people.
Thank you, Trevor. And now we will move to Dr. Emily Chapman, the new CEO of Children's Minnesota, but I've known Emily forever, it feels like. And Emily, what say you?
I'm not sure. Oh, I do. Nice. I did it. All right. So Emily Chapman, Children's Minnesota. If you're not familiar with Children's Minnesota, we are, by pediatric independent health system standards, a very large independent freestanding children's health system in the top 5 to 10 in the country. What an opportunity we have in terms of delivering specialized pediatric care in our state of Minnesota. We've got about 450 beds. We've got about 6,000 plus employees. We've got various clinics and ambulatory surgery centers and rehab sites and so forth and so on. We're largely focused in the Twin Cities area in terms of our physical location. We take care of children from every single county in this state. We train in partnership with University of Minnesota and many other institutions. 75, 80% of those who go into caring for children in this state. So to your point, Trevor, it's incredibly important that we think about this. Medicaid, we think about who is served by Medicaid. The vast majority of people served by Medicaid are children. And I think that gets lost from time to time. So when you hear the description of the health of our health systems, we're in exactly the same position. We're dealing with all of that same stuff. Our goal as an organization is to make sure that in the state of Minnesota, we are available as a puzzle piece to receive that pediatric challenge that exceeds what we're comfortable managing in whatever system is turning to look to us. Every system is that we can take the handoff when it doesn't make sense for Trevor to have a pediatric intensive care unit or certain inpatient specialties or what have you. Our job is to take that. and is to take that from this entire industry in our state. So it's critically important, and it's critically important that we be here. At the same time, we have this equation going on, and we're trying to manage through that. But with our heads down trying to manage through that, there's a tremendous risk developing. Not only is there a risk of our being able to collectively serve the health needs of our state, what we haven't even mentioned for a moment here is that the puck is not going to stay right here in front of us. The puck is off there, and we need to be, as medical communities, skating to where the puck is going to be. And I'm talking, as a physician at the moment and a CEO, I'm talking about the clinical care. We're all talking about how to pay for yesterday's clinical care and our ability to intervene on chronic diseases and treat emerging diseases and so forth. That's not going to do it. We need to be looking at where care is going. So how are we going to start to think about the idea of intervening in diseases that then show up in your 40s and your 60s and in these healthcare systems? How do we intervene on those? That isn't something that any one of us can do together. So if you're working to develop something like Children's Minnesota and the University of Minnesota developed together in partnership with each other and with the Children's Cancer Research Fund, where childhood brain tumors can be met with new therapeutics that address that specific type of tumor. So a whole slew of pediatric brain tumors studied by this consortium over a 20-year period of time and collaboration find that darned if that brain tumor doesn't make a molecule that acts like a shield so that all of our known medications that fight these cancers can't get to that cancer. We got to break down that shield. We did that. We did that together. Those kinds of collaborations need to be supported in that same macroeconomic and regulatory environment that is doing all of this. And I don't think we're talking or thinking about the ways in which we need to ensure that our financial and regulatory environments support, maybe even encourage, those kinds of partnerships that help us do that. A lot of medications come into the adult side of healthcare. They're developed because there's a very large population. There's some common diseases that you see in all of them. The challenge in pediatrics is that we have a smaller population of patients, but we have those patients where the chronic disease or the life-limiting disease starts. So for us, in addition to what we're talking about today, we're trying to look at how do we actually develop and bring to the bedside these genetic therapies which interrupt inherited metabolic diseases that lead to early death, that lead to lifelong support in our healthcare systems to manage these kids. So I encourage us, as we're going through this, to think about, as we reimagine how we're going to do this, that we think not just about rebuilding a healthcare system that meets today's needs with today's scientific knowledge, but that we think about what it's going to take to meet tomorrow's needs and the opportunities that we have to support, to in fact create a healthier community that is less of a impact on all of us. It's going to take our rethinking old regulatory requirements, old models of what prior authorization looks like and how we begin to support orphan medications that are going to change the face of our community and so forth. This is a room where that kind of conversation needs to happen. Our scientists are trying to do it, but they can't do it without the financial and regulatory environment that allows them to actually make this a reality.
In our remaining 2 minutes, I am going to do a lightning round. there are policy experts and lawmakers here, but I also see state agency leaders here who are our deep partners. Most actively, I see some folks here that are actively working with us on the Rural Health Transformation Program, for example, and writing this application as we speak. There are partners that are working with us on another very important program that we've been working on called Directed Payment Program. All these acronyms, there's so many acronyms. So a lightning round, if you were to ask for one thing for the policymakers and agency leaders to focus on in service of the nonprofit hospitals and health systems, what might that be? And I know the list is at least 100, if not 500 points long, but what would you say? We'll start with James, come back over here. So James?
Well, I think in the short term, look seriously at regulatory reform. I mean, every day I have at least 2 or 3 people visiting my hospitals, and 99.5% of the time, nothing is found. But we tie up at least 8 FTEs every month to be able to manage those. That's not a good use of resources. In the longer term, and I realize this is probably not possible, we need to have a serious conversation about healthcare reform and how we both finance and deliver care. And then Emily brings the right point up, which is, and how do we continue to invest in the science of care? Because ultimately, that's going to be the thing that makes the difference.
Thank you, James. Rachelle?
I'm not even sure how to answer that question, but what it really comes to mind for me is it's on the regulatory side. This is a time we have to be bold. We have to stop doing CPR on a system that is falling apart, that is past its prime, that's dying, and create the new. And I think in that, a lot of us on the healthcare side, want to step out, we want to be bold, and we need partners to do that. So I think it's about reducing sort of those regulatory barriers and have partners that will be bold with us.
I appreciate those 2 points very much, and allows me to say, first, do no harm. I know every program that you want to talk about, 340B, the provider-based billing, some new regulatory environment for what staffing should be, all those things are really smart and rational and are rooted in common sense. The system is too fragile for common sense in a lot of ways right now. Don't do anything without fully understanding what it is that you're going to do and how it's going to impact a very, very fragile system.
And I would say, don't forget about preventative care. We are walking away from supporting the cost of primary care, preventative care for our total population, and we are walking away from the science that has established the criticality of intervening early to make sure that our population stays healthy. So whenever you're reviewing something that has to do with funding or official recommendations or regulatory aspects of the work, think about, does this encourage and support every member of our community to get the necessary preventative care so that they're healthier, they contribute to society, and they aren't adding to our burden of disease that we are seeing in our state.
How lucky am I that these are the kinds of leaders that I get to work with every single day, and since COVID especially, it's been a 7 days a week, 24/7 endeavor, and so talking at 5 in the morning does not feel like work, or talking over a weekend or a holiday with you all and the other nonprofit leaders across the state does not feel like work, because at the very end of the day, the caregivers are touching patients. You all, so many of you outside shared with me, one of you had a ruptured appendix, one of you just recovered from COVID, one of you your husband was just in the hospital twice, getting care in these institutions. So I count myself as blessed because I live in the state of Minnesota, which where you all lead the people that provide the care. You all are the caregivers of the nonprofit hospitals that do what you do. And so a heartfelt thank you from the Minnesota Hospital Association perspective, because we have had the privilege of supporting you in every way for almost the last 110 years. So audience, please give these leaders and their teams a round of applause.
Again, that's Rahul Koranne, President and CEO of the Minnesota Hospital Association, speaking at the State of Reform Conference in Bloomington. I'm Abby Mochtig, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.